Good morning, and welcome to the 11th Annual Virginia Patient Safety Summit. Still virtual, but gang, I'm already feeling the vibe. I'm Ray McCue, Vice President for Medical Affairs and the Chief Medical Officer for Chesapeake Regional Healthcare. In Chesapeake, Virginia, you can see our beautiful facility right behind me. It's been my honor to serve as chair of the Planning Committee for this 11th year of the Virginia Patient Safety Summit. The summit is an annual opportunity to celebrate safety improvement work being done in Virginia hospitals and to acknowledge the individuals, teams, and leaders who help make Virginia a great place to receive care. In normal times, the Safety Summit has been a full day and a half event in person at the Richmond Downtown Marriott. However, due to the ongoing impact of COVID-19 public health pandemic, we are gathering virtually for a second year in a row. Despite the virtual format, we are pleased that we have had the opportunity to expand the level of engagement and participation in the event by achieving a registration of over 1,300 individuals, so kudos. We are pleased to announce that this year's summit is again being presented in partnership with the Virginia Nurses Association, the Medical Society of Virginia, and Virginia Pharmacists Association. The theme for this year's summit is resilience, the cornerstone of Virginia healthcare. Resilience, that's a word we hear frequently. If we look in a standard dictionary, we'll find two basic definitions. The first is from a materials and engineering perspective. It is the ability of a substance or object to spring back to its original shape and retain its properties following the application of a stress without breaking. Synonyms for that definition would be flexibility, pliability, elasticity, and suppleness. But the bottom line, it's the ability to withstand stress without breaking and still return to the original form. Second definition is simple, but has far more connotation. The second definition is the capacity to recover quickly from difficulties. The synonym associated with this definition is a simple word, toughness. That's also become a one-word description for all of us who work in healthcare today. Resilience is a topic visited across the entire social spectrum these days, and there's hardly a self-help website or a guru promoting their wealth scheme or entrepreneurship that doesn't devote some part of their program to resilience. Many businesses that retain a wellness program for employees add resilience. Mayo Clinic, for example, on their website, they have a section devoted to employee wellness. Their staff has put together a comprehensive program with an emphasis on resilience. Their module covers the topics on many levels, but focuses on the personal well-being of employees, both physically and emotionally. They start out with a very simple question. When something goes wrong, do you tend to bounce back or fall apart? They define resilience as the ability to harness inner strength and move forward and avoid pitfalls, such as substance abuse and depression. We're all aware of the shortages of healthcare workers, exacerbated by retirements, attraction to alternative work, and yes, burnout. Many in our line of work are self-reflecting and asking ourselves tough questions about what is important in our lives. Where should our priorities lie? On this topic, I'm happy to welcome Brian Sexton back this year. For those of you that participated last year and heard Brian's presentation on burnout, you will recall he provided a scientific and measured perspective of the challenge. He actually had real data to share with us. This was clearly one of our 2021 highlights, and I encourage everyone to attend his presentation as we examine these stressors and how they affect us as individuals and in industry. Today at the summit, we're also addressing resilience as it affects not only Virginia healthcare, but the entire spectrum of healthcare in this country. As we are finishing our second year of the pandemic, and we see the virus begin to fade into an endemic form, along with the 6 other coronaviruses that infect humans, we're starting to look at resilience from a broader perspective. But we, the healthcare system in the Commonwealth of Virginia, did not break from the stress. However, how will we measure our resilience? With that in mind, I encourage all of you to listen to our keynote speaker, Dr. Arjun Srinivasan. We were fortunate to have him participate in our safety summit last year, and it speaks to the CDC's commitment on this important subject to have him back again and share his insights. He is a co-author of a provocative article in this month's New England Journal of Medicine, along with primary author Lee Fleischer. It's entitled Healthcare Safety During the Pandemic and Beyond, with the subtitle, Building a System that Ensures Resilience, that word again. As we come out of the pandemic, Arjun will address what I find to be the most provocative aspect of future discussions. We talk about resilience, but what do we return to as we go back to our form? We clearly haven't and will not break, no matter how close we may have come. However, Dr. Srinivasan will ask, what is the form that we expect to return to? Will we have warped, or will our systems, hospitals, and the way we provided care have a different shape after this experience? Is that necessarily bad? It's now the time to take a good, close look at our systems and all lessons learned. I ask this not only to be prepared for the next pandemic, but also to improve on what was before. In a crisis, the weakness of any system will be accentuated. As an example, look at the disparity in access and delivery care that became apparent early on. The old triple aim, of course, now quadruple aim. But it gets back to what is normal and what should normal be. Resilience. To describe the last 2 years in healthcare as a challenge was an understatement. But what a testament to those of us inside the pandemic. Over these last 2 years, we improvised, learned how to accelerate, share, and apply knowledge rapidly across the entire sector. You know, as someone who stood in line for the first polio vaccines administered on a sugar cube back in the 1960s, we saw a true technological marvel in the development of the mRNA vaccines. We continue to make our hospitals safer for patients and our staff. We stay committed to bring the highest quality of care to the bedside, state of the art, even as treatment was changing and evolving on a weekly and even daily basis. Day in, day out, we never compromised on the compassion that our patients needed to deal with this unexpected burden, especially the frequent and sudden end-of-life issues with families in crisis. By necessity, we had to mitigate the toll and get our nurses and providers right back online. They were needed at the bedside to help the next family, the next patient in similar crisis. The question now is knowing the true costs to us as individuals and the facilities we work in. What are we preparing to return to in healthcare? During this year's Safety Summit, our speakers and the various breakout sessions will address many of these concerns. In closing, although I can't know the form or shape, I do know one thing to be absolute truth. Safety, quality, and the patient experience will continue to improve in Virginia healthcare because of our resilience. I know without question, Virginia hospitals will be better for this experience. In Virginia, we only know one direction, and that's forward. At this time, I'd like to acknowledge and thank the members of this year's Planning Committee for their efforts and contributions to the assembling of what we believe is an excellent program that includes not only national speakers, but a showcase of great work occurring in many of our Virginia hospitals and health systems. The names of the members of our Planning Committee are here on the screen. I would also like to thank the generous sponsors whose financial contributions have made it possible for us to make this event available to all our attendees at no charge. I encourage you all to visit our sponsors' pages and the booths in our virtual exhibit hall. Finally, this past fall, the VHHA staff traveled across Virginia to thank and recognize healthcare workers in many of our hospitals and health systems. During those travels, they were able to capture the voices and hear the experiences of many staff members directly involved in the response to the COVID-19 pandemic. I would like now to present to you a few of those voices. Listen to how common our shared experience was across a very diverse Commonwealth. Thank you. Please enjoy, learn, try to share. Next year, we will be together. not seeing the video.
We were very proud to be able to take care of the patients in the way that we needed to take care of the patients that came in with COVID. Now we're focusing on taking care of our team members who are feeling the after effects of dealing with everything that we dealt with COVID. Part of an amazing team, couldn't be more proud of the ED team that we work with.
Very emotional, but at the same time I can say that I've learned a lot. And I've learned how awesome my team is and how close we've become through this experience. I mean, if I could go back and change it, of course I would. No, I would never wish this to happen ever again, but I mean, here we are and hopefully we can get through it.
But I tell you, the teamwork that we've seen around the hospital, the collaboration, the support of our non-clinical areas to our clinical areas has been just amazing to witness.
My staff in my women's and children's areas are so resilient. They've been through a lot of struggles over the last 18 months. And, you know, we see moms in what's supposed to be the happiest times of their lives, and this has disrupted it a little bit, but our staff have picked up and been all of the support that they can be and offer.
The team in the laboratory has worked tirelessly throughout the entire pandemic to process these tests in a timely manner so people know whether they have COVID or not. They know which directions to take when it comes to isolation and things of that nature. And they have been there the entire time, working in dire straits sometimes with staffing and other things, putting themselves on the line to do this testing. So we're super grateful for all of our laboratory professionals right now. And as we continue to see our positivity rate decrease, we're hoping that we're seeing the light at the end of the tunnel, but the lab staff will be there no matter what happens.
We've been hit pretty hard at Augusta Health with COVID. Everyone seems to be pulling through. Nursing staff have worked their tails off. So grateful to have them here.
I think that it really brought everyone together as a team. Obviously, nursing is a team sport anyways, but when you're faced with something so big and so overwhelming, everyone really comes together, and we had a lot of support from the community too. I know when we were faced with this, we had so many people bringing us food. I know I walked to my car one day and they had firefighters and police officers and everyone out there, and people from the community with signs just thanking us for our service, and that really hit home for us because, like I said, you know, we really weren't getting to talk to a lot of people, see a lot of people, and so having that level of support meant a lot to us and helped really push us through.
Well, good morning, everyone. And thank you, Dr. McCue, for such a wonderful opening. And what an incredible video to watch. It's always so inspiring to hear the heartfelt comments from our team members. Good morning, everyone. Thank you for joining us today. I'm Steve Arner, Executive Vice President and Chief Operating Officer at Carilion Clinic, headquartered in Roanoke, Virginia. For the past year, I've had the privilege of serving as chair of the board of directors for the VHHA. After last year's Patient Safety Summit, which focused on clinician burnout and stress among healthcare workers, the VHHA Board of Directors commissioned a task force focused on how can we better support and care for and improve the well-being of our caregivers. This task force was led by Dr. Tracy Hoke from the University of Virginia Health System and Dr. Joel Bundy from Centera Healthcare. The group presented recommendations back to the VHHA board, which were unanimously passed. You will hear more about this task force and their recommendations later this morning. You know, much of our ability to be resilient over the past 2 years can be attributed to the incredible partnerships occurring across the Commonwealth. These partnerships, as represented by the VHHA, the Medical Society of Virginia, the Virginia Nurses Association, and the Virginia Pharmacists Association, have created new and innovative ways for us to meet the acute needs and the public health needs of our communities. In addition to these partnerships, the partnerships between the private and public sectors have been nothing short of remarkable. The VHHA and its member organizations partnered with our state and local government agencies, including the Virginia Department of Health and the local health departments, on so many initiatives so that we could appropriately and quickly respond to the public health emergency. As an industry, we are truly honored to be able to serve and support the state in the state's COVID-19 response efforts. On behalf of the VHHA Board of Directors, I would like to thank all of you for your hard work and resiliency in responding to the pandemic and for sustaining cultures of safety and high reliability in each of your organizations. I am continually impressed by our collective response and your commitment to serving our communities. My sincere appreciation for all that you do. Thank you, and thank you again for joining us today. Now, to kick off our 2022 Patient Safety Summit, we have a special message from Governor Youngkin. Although Governor Youngkin is not with us in person this morning, we do have a video we'd like to share with you at this time. Thank you.
Greetings, everyone. I want to say thank you for attending the 2022 Virginia Patient Safety Summit virtually, as well as everyone who promotes safe healthcare practices across the Commonwealth. Your work is invaluable to ensuring that Virginians have access to the highest quality healthcare. As your governor, I will work to ensure that you have all the tools necessary to keep Virginia healthy, especially during this COVID-19 pandemic. It's critical that we keep healthcare workers safe, both physically and mentally. I appreciate all of the work that you're doing, and have a great Patient Safety Summit.
Good morning, everyone. My name is Abraham Segrist, Vice President for Quality and Patient Safety here at the Virginia Hospital and Healthcare Association. As many of you know, in 2016, the VHHA launched the VHHA Center for Healthcare Excellence to coordinate statewide quality, safety, and service improvement efforts among Virginia hospitals and health systems. The vision statement for the center is Imagine a Virginia. Imagine a Virginia that achieves zero harm to all patients. Imagine a Virginia that ensures a safe environment for all patients and families, staff, and visitors in healthcare organizations. Imagine a Virginia that delivers high-value healthcare, top-tier quality and safety at the lowest cost. Imagine a Virginia that provides for resiliency in the workplace and promotes joy in practice and work. Imagine a Virginia that provides an optimal patient and family experience always. Imagine a Virginia that understands and adopts reliability as an operating system in healthcare. Imagine a Virginia that designs and implements healthcare work processes to reflect evidence-based best practices. And finally, imagine a Virginia that influences and reinforces behavior accountability of individuals, teams, and organizations. Since the launch of the center, the VHHA has made a concerted effort to support all Virginia hospitals in their quality, safety, and service improvement endeavors. Facilitating quality and safety improvement projects throughout the year and hosting the annual Patient Safety Summit are all part of this ongoing effort. The VHHA also takes pride in recognizing the efforts of individuals, teams, and organizations who contribute to the pursuit of the Imagine a Virginia vision. In 2017, the VHHA launched its first Imagine a Virginia Senior Leader Quality and Patient Safety Award at our annual Patient Safety Summit in Richmond. This award recognizes individuals in executive level positions in Virginia hospitals who demonstrate leadership in patient safety and quality improvement that transcends the bounds of their own hospital or health system. These leaders consistently encourage the development of a culture of safety and make patient safety and quality improvement a top priority for their organizations. They also willingly share best practices, ideas, and setbacks regarding their organization's journey to improve quality with other Virginia hospitals and health systems. Due to the constraints of COVID-19 pandemic, last year we held the annual Patient Safety Summit virtually and traveled to the award recipients organization in advance of the summit to present the award. We did the same again this year. It is our pleasure to recognize Nancy Littlefield, Executive Vice President and Chief Nursing Officer with Riverside Health System, headquartered in Newport News, as the 2022 recipient of the VHHA's Imagine a Virginia Senior Leader Award. As a recipient of this award, the VHHA is recognizing the leadership Nancy has demonstrated within Riverside Health, as well as the leadership and vision in patient safety and quality that she has demonstrated at the state level. Nancy's strong and steady leadership for our VHHA Patient and Family Experience Forum over the past 3 years, and her longstanding vision of more active engagement by chief nursing officers in the work of the association are just two of her contributions to promoting high quality, safe, and patient-centered care across the Commonwealth. Nancy has been a consistent voice in imagining a Virginia that provides an optimal patient and family experience always. We were able to travel to Riverside earlier this week to present the award to Nancy, at which time we recorded these remarks.
I'd like to thank the VHHA and Abraham and so many that I've had the privilege of working with to accept this wonderful award. I've worked with such amazing people, not just at Riverside Health System, but all throughout the state. And I feel very humbled that I'm the one chosen to get this award, but thank you so very much, and let's keep up the good work.
In 2017, the VHHA also launched our quarterly Virginians Speak Up for Safety Awards program. This program is designed to recognize the efforts of individual staff and providers within Virginia hospitals who speak up to prevent potential harm to patients or other staff members. Employees who feel safe and empowered to speak up to peers, as well as to those in authority, are able to do so because of a positive safety culture organization. In fact, highly reliable organizations make sure that everyone not only feels free to speak up, but also recognizes an obligation to do so because their organization's values the information as a vital component of its journey to achieving zero harm. It is now our pleasure to recognize the 2021 quality winners of the quarterly winners of the Virginia Speak Up for Safety Award. Starting in Northern Virginia, we have Carolyn Boyd with the Nova Alexandria Hospital, who was recognized in the first quarter. In the first quarter, we also recognized Jenny Talley with Augusta Health in Fishersville. Second quarter, we recognized Kimberly Moore with Riverside Regional Medical Center in Newport News. And we also recognized Jessica Powell with Fauquier Health in Warrenton, Virginia. In the third quarter, we stayed here in Richmond and traveled downtown to recognize Tammy Scott with the VCU Health System, and then traveled to Williamsburg to recognize Jennifer Beaver with the Centera Williamsburg Regional Medical Center. And then finally, in the fourth quarter, we recognized Mary Allen with the University of Virginia Health System in Charlottesville. We traveled to Norfolk to recognize Lauren Winfield and the team at Centera Lee Hospital in Norfolk, Virginia. We would like to congratulate and thank you all for speaking up to ensure safety in Virginia hospitals. Finally, over the past several years, the VHHA has sponsored a variety of programs and opportunities for Virginia hospital staff and providers to strengthen their knowledge and comfort level with the science of healthcare improvement. This past year, the VHHA Center for Healthcare Excellence partnered with the Institute of Healthcare Improvement in their open school to provide 100 Virginia hospital staff, providers, and leaders the opportunity to obtain a certificate and quality and patient safety. This certificate process included the completion of 13 online learning modules with access to a total of 30 online learning modules. This morning, we are proud to recognize the 70 participants who've already completed their 13 course assignments required to receive their certificates. The other participants will have until April to complete their assignments. In addition to receiving their certificates, these 70 individuals have also earned 17.5 hours of continuing education credits. Our 2021-2022 VHHA IHI Quality and Patient Safety Scholars are as follows. From Augusta Health, we have 3 scholars. From Bath Community Hospital, 1 scholar. From Bon Secours, Mercy Health, 7 scholars. Carilion Clinic, 9 scholars. Centra Health, 1 scholar. HCA Healthcare, 6 scholars. Inova Health System, 2 scholars. LifePoint Health, 4 scholars. Longleaf Neuro Medical Treatment Center, 1 scholar. Mary Washington Healthcare, 4 scholars. Centera Healthcare, 18 scholars. UVA Health, 8 scholars. Health, 3 scholars. VCU Health, 1 scholar, and 2 scholars from our team here at the VHHA. Please join me in congratulating our VHHA IHI Open School Quality and Patient Safety Scholars. This spring, we will offer another opportunity to participate in the IHI Open School program. If you may have interest in participating in the next cohort, feel free to reach out to our colleague Joyce DeVault on our team. As we prepare to hear our first keynote speaker at 10 a.m., here are a few attendee instructions to help you get the most out of the 2022 Virginia Patient Safety Summit. We will have all of our participants muted throughout the entire program today. However, we encourage you to place questions in the question box for the speakers as you attend the sessions. Also, feel free to chat throughout the presentations with your colleagues. And at the end of each session, return to the auditorium to access the next presentation. There are about 25 on-demand videos available in the auditorium tab. We encourage you to take a look at those videos at your leisure. All attendees will have access to this event platform for 30 days. Slide handouts from today's live events will be posted tomorrow morning. Recordings from today's live session will be posted in 48 hours. Follow links and instructions available in the Continuing Education tab to attain credits. At this time, I will now turn to my colleague, Dr. Raymond McCue, who will introduce our first keynote presentation. Dr. McCue, I'll turn it back to you.
Thanks, Abraham. It's now my pleasure to introduce our first keynote speaker. Dr. Arjun Srinivasan was with us for the Safety Summit last year. We're glad to welcome him back to Virginia. Dr. Srinivasan is the Associate Director for Healthcare Associated Infection Prevention Programs in the Division of Healthcare Quality Promotion at the Center for Disease Control at the National Center for Emerging and Zoonotic Infectious Disease. He's board certified in infectious disease. Before joining the CDC, he was an assistant professor of medicine in the Infectious Disease Division at the Johns Hopkins School of Medicine. He was the founding director of the Johns Hopkins Antibiotic Management Program and the Associate Hospital Epidemiologist. His research and investigative areas of concentration include outbreak investigations, infection control, multi-drug resistant gram-negative pathogens, and antimicrobial use. From 2006 to 2010, he led the CDC's Healthcare Outbreak Investigation Team. In 2008, he assumed the medical directorship of the new CDC campaign called Get Smart for Healthcare, which is designed to improve the use of antimicrobial in inpatient healthcare facilities. A graduate of the Vanderbilt University School of Medicine, he has completed internal medicine residency and infectious disease fellowship at the Johns Hopkins University Hospital. Dr. Srinivasan is an adjunct professor, assistant professor of medicine at Emory University Medical Center and sees patients at the Atlanta Veterans Affairs Medical Center. The title of Dr. Srinivasan's talk this morning is Moving Forward and Back to Normal, Building a Better Systems for Patient Safety. With a primary focus on healthcare-associated infections, Dr. Srinivasan will discuss some of the patient safety lessons we've learned over the past 2 years and what those lessons mean for the future of healthcare policy and patient safety in the US. After his talk, we will have a few minutes for questions, so feel free to put the questions in the question box throughout the presentation. Please join me in welcoming Dr. Srinivasan back to Virginia.
Ray, thank you so much. I want to thank thank Abraham, Michelle, all of the organizers for giving me this opportunity to be with you. Sadly, once again, virtually, but I sincerely hope that you'll have me back one more time next year so that I can see you all in person at the Marriott in downtown Richmond for this incredible conference that you guys put together every year. As I don't have any financial disclosures, as Ray mentioned, I am a full-time employee of the federal government of the United States. And as Ray said, I am going to talk about patient safety and getting back to, quote, normal through the lens, my lens, which is infection prevention and antimicrobial use and resistance. But I do think that there are some important lessons learned here that are transferable across all of our experience in healthcare. And, as we begin to think about what normal looks like and getting back to normal, I think it's important to define what that normal was. What was the state of play before we entered the pandemic? And from my field in healthcare epidemiology and infection control, we were actually seeing some nice successes of our efforts to both reduce healthcare-associated infections, to reduce antibiotic resistance, and improve antibiotic use. And those successes were fantastic, but it's important to go back and look and understand that those successes were not uniform in their distributions. There were important disparities in our successes. We have made great progress in saving patients' lives by preventing central line associated bloodstream infections. We've seen dramatic drops in these infections over the past several years. However, if you go back to 2019, you can see that 9% of the hospitals were doing significantly worse than average. So you had a lot of hospitals that were making tremendous progress, but there were a subset of hospitals in the United States, 9%, so not a small number of facilities that were significantly worse than the national average. They were lagging the progress that everyone else was making. When we look at antibiotic stewardship programs, this is showing the percent of all hospitals in the country that had an antibiotic stewardship program that incorporates all of the best practices for stewardship programs that we set forth in what we call the CDC 7 core elements of stewardship programs. And again, here you see some important disparities, right? So hospitals that had more than 200 beds, larger hospitals, 66% of them had all 7 of these elements in place in 2015. But when we moved to critical access hospitals, only 26% of them had all 7 of these elements in place. And so that suggests some important structural disparities that may lead to problems and challenges with antibiotic use at these critical access hospitals. And of course, that's not something we want, right? We want anyone, no matter which hospital they get admitted to, no matter how big it is, no matter how small it is, to get optimized antibiotic use under the direction of a stewardship program. We see this same difference in antibiotic prescribing when we look at outpatient prescribing. This is a heat map showing the number of antibiotic prescriptions filled by outpatients per 1,000 populations for all of the states in 2019. And you can see there are major differences in the rates of antibiotic prescribing, almost a 100% difference between the lowest at around 450 and the highest at over 1,200. And again, this is not to say we don't fully understand if all of the low use is good and all of the high use is bad. However, we do know that in some of these states with very high rates of prescribing, there's a lot of evidence suggesting that a fair bit of that prescribing is unnecessary. Those are patients being exposed to antibiotics they don't need which means they're taking medications, being exposed to side effects of medications to treat conditions that they don't have or that the antibiotics won't treat. So important discrepancies in outpatient antibiotic prescribing. We also see these same types of discrepancies, and let me move this panel to the bottom here. When we look at antibiotic-resistant organisms, we see significant disparities. Again, this goes back well before the pandemic, based on socioeconomic factors, things like race, gender, with several of our major healthcare pathogens, right? Methicillin-resistant Staph aureus, extended spectrum beta-lactamase producing organisms, Clostridioides difficile, Candida, all of these organisms disproportionately affecting Black citizens, disproportionately affecting poorer populations. So important discrepancies in who is suffering the consequences of these drug-resistant infections. We also know that these disparities persist even when we see progress. So from 2005 to 2014, we made good progress in reducing the rates of invasive hospital onset MRSA infections in our healthcare settings. However, even when we saw that decline, it wasn't shared equally. Even at the end in 2014, the rates of infection for Blacks remained significantly higher than infection rates for whites. We saw these same challenges and disparities when we went to COVID as well. And this is data from the nursing home sector. And what we know historically is that nursing homes that have high Medicaid populations, so if 85% or more of the residents are on Medicaid, those are nursing homes that are operating in more resource-constrained settings. On average, those nursing homes have lower quality scores, lower financial performance. They have lower star ratings. Well, why is that important? What we saw during the COVID pandemic is that nursing homes that had those lower quality scores had significantly more COVID morbidity and mortality during the pandemic. So again, we see a disparity here in the quality of care that can be delivered, resulting in hospitalizations and even deaths among nursing home residents that are in these homes that have the lower quality scores associated with more resource constraints. Talking about back to normal, healthcare staffing was also an issue. Again, this predates the pandemic, right? This was our normal pre-pandemic. We were understaffed throughout healthcare, but especially so in our nursing and our assistant staffing. These are just two studies demonstrating. One is that nursing homes had major staffing challenges well before the pandemic. This has been an issue that the nursing home sector has been struggling with for many, many years. And here's another study on the registered nurse workforce. And this, if you look at the date, this is 2018. Major shortage challenges in our nursing workforce, again, definitely predating the pandemic. So this was our, quote, normal state of affairs pre-pandemic when it came to healthcare staffing. And the challenge is not only do we have healthcare personnel shortages, but during the pandemic, even the people that we had were pulled away from their normal activities, and we had to redeploy to do COVID work. And we saw the consequences of that in infection prevention and in antibiotic use. Here's a fantastic study from right here in Virginia. And again, Michelle, who's going to join me in a second for our panel discussion, is one of the co-authors here. They looked at the impact of COVID on their infection prevention efforts. And in their survey, 79% of the staff that they surveyed spent more than 3/4 of their time on COVID response activities, right? So the vast majority of their time being spent on COVID-19 response efforts. That means all of their other work, preventing central line associated bloodstream infections and pneumonias and Clostridioides difficile, preventing MRSA infections. The majority of that other incredibly important work had to be put on hold while they redeployed their efforts to COVID-19. We saw the same challenge when it comes to antibiotic stewardship programs. This is a survey from hospitals in Michigan, and you can see that almost every hospital that they surveyed, the stewardship program indicated that their time for the antibiotic stewardship work that they had been doing was either somewhat or strongly decreased during COVID. Again, those stewardship efforts had to be redeployed in order to manage the COVID pandemic. The COVID pandemic work was obviously vitally important, but so was all that other stuff that they were doing that had to be put on hold. The other challenge that we faced pre-pandemic, of course, was that our data, our ability to know what's going on with healthcare-associated infections, what's going on with antibiotic use, were not nearly what we would like. In the nursing home sector, pre-pandemic, there were only about 3,000 hospitals that had ever reported any information on healthcare-associated infections into CDC's National Healthcare Safety Network, our national tracking system. So we really didn't have much information about what was going on in nursing homes when it comes to healthcare-associated infections and antibiotic use. Hospitals mostly do report. There are many CMS mandates for hospitals to report data into the National Healthcare Safety Network. However, the overwhelming majority of that reporting is manual entry, right? It's incredibly burdensome for the hospitals that have to do that reporting. And we lacked any information source on hospital capacity and hospital resources like personal protective equipment. That was a huge challenge early on in the pandemic, and we struggled, and in fact, we still struggle to make sure that we have this information. So that was a problem that we brought into the pandemic. In many situations, we had only proprietary data sources, particularly when it comes to antibiotic use. You have to buy this data. It's not publicly available. And we had very little data on antibiotic use in hospitals. So there were a lot of data challenges that were normal coming into the pandemic. We also know that our infection prevention and stewardship gains, all of that progress that I mentioned earlier on, were almost exclusively built on educational and behavioral interventions. The successes that we had were largely dependent on people doing the right thing in every situation, remembering to do that every time, and having the time to do those practices time and time again. Checklists are incredibly powerful, right? They have been transformative in medicine, but they're only a useful tool if you have the staff and you have the time to complete them. And we know during the pandemic, we didn't have enough staff, and the staff that we had absolutely didn't have enough time for a lot of these practices that we had built our infection prevention successes on. As a result, it's no surprise to anyone, I think, that the occurrence of these infections rose dramatically during waves of the pandemic. We saw increases almost across the board: central line-associated bloodstream infections, catheter-associated urinary tract infections, ventilator-associated events, methicillin-resistant Staph aureus bacteremia. All of these went up significantly during the pandemic. And I think, again, that's a reflection of the fact that our safety practices eroded when we encountered these waves of COVID patients and the struggle to take care of large influxes of patients with reduced numbers of staff, more demands on our staff time. There's a lot of talk then about, do we go back to normal? Can we get back to normal? And I think for us in healthcare, I think the answer is no. We don't want to go back to normal. We want to move forward. We want to get to a new normal. But what lies in those quotation marks? What does our new normal look like? Well, I have a few lessons learned, I think some ideas. Again, I don't have the solutions to all of these, but I think these are the ideas that we need to think about as we think about coming back to a new normal. One is striving for uniformity in our prevention successes. There is a lot of focus right now, and it's wonderful, on health disparities, right? This is a topic that I think is finally getting its due. For healthcare epidemiology and stewardship, I think there are two levels of disparities that we have to think about. And again, I think this holds true for a lot of the disparity work that we do in hospitals. There are disparities at the patient level, right? Does the patient have access to care? Does the patient have the health literacy to understand the recommendations that their provider is making? But there are also disparities at the facility level, right? Like I showed you earlier, critical access hospitals may struggle to do some of the things that larger hospitals might take for granted. I think right now, a lot of our efforts in disparities and a lot of our attention is focused at the patient level, and that is really good. However, we also need to think about an equal focus on understanding disparities at the facility level, both in hospitals and nursing homes. What are the facility level factors that might underlie lagging success or failures in infection prevention and failures in stewardship? And how can we address some of those facility level disparities? And I think there is a note of optimism here, because we have definitely seen success. If we look to understand and address the drivers of disparities, we can make transformative change at the facility level. And an example from my world, when we saw that data coming from critical access hospitals, that they were lagging so much, the larger hospitals, in their implementation of stewardship programs, we went to them. We went to the critical access hospital community and said, we want you to be able to have these core elements, to have these stewardship programs. We see that very few of you do. Help us understand what are the unique challenges that you all might have in implementing these stewardship programs, and teach us for the hospitals that have been able to do it, teach us how you've done it so that we can share that with others, right? So we engaged that community at the start. It's the idea of nothing about us without us, right? Let them show you how to get it done. And what the result of that was is we developed an implementation guide for antibiotic stewardship programs specifically tailored to critical access hospitals, written in collaboration with critical access hospitals. And what we have seen over the last few years is that the implementation of these stewardship programs in critical access hospitals has gone from 23% to 83%. It's a tremendous success when we focus our efforts at understanding the disparities and working with those most affected to understand how to overcome them. We can do this at the facility level. We also know that we have to rethink staffing. And again, my focus here is on infection prevention and stewardship staffing, but I think it applies across the board. Staffing in all of healthcare has been a huge challenge. Our bench is too small. And in my field, we know that anytime a crisis comes along, this time it was COVID, previously it was Ebola, pandemic influenza, SARS, MERS. Anytime there's a crisis, our infection prevention and stewardship staff have to redeploy their efforts in order to address that crisis, which means that their normal activities often come grinding to a halt. And that can have real consequences. As the data I've shown you, more patients get infected, more patients develop resistant infections, consequences of unnecessary antibiotic use, because we have to take offline some of our stewardship and infection prevention efforts. Broadly, we need to attract a lot of new people to our fields. That includes infection prevention and stewardship. It includes nursing assistants. Maybe that means more of a focus in undergraduate training programs, drawing more people into the full spectrum of healthcare professions. Another thing that will help is making sure that all of our healthcare personnel are better trained. This is particularly true, we think, in infection prevention. So rather than having to pull everybody offline in order to provide just-in-time training to staff in infection prevention approaches, what if our healthcare workforce was already trained really well in infection prevention and control approaches, so that all we had to do in a crisis is say, hey, you've already been trained, you know what to do, here are the specific infection control recommendations for this pathogens, but you already know how to implement them. We are working on that at CDC. We have a new effort that I hope you're all familiar with called Project First Line. And it is a first ever effort to provide tailored infection control training to all 6 million, roughly 6 million healthcare providers in the United States. And so we're looking at developing training that is not the traditional training of the 45-minute or 1-hour PowerPoint presentation that you have to, kind of suffer through, but we're looking at doing training that is taking advantage of new concepts of training, short focused training, and training that is highly tailored to job categories. So what does a respiratory therapist need to know? What does someone in a nursing home need to know? So that program is underway. I think it's entering its second year now, but this hopefully will provide that level of baseline training so that when a crisis comes, we don't have to redeploy our infection control staff in order to provide that training. And this is the type of new approach that we want to see in our new normal. What are the ways that we can prepare our workforce so that if and when, I should say, another pandemic comes, we're better prepared to help our staff deal with it. We also need better information. You know, we can't act in healthcare without good information. So getting that information is vitally important to informing our efforts to respond at baseline to any problem that we have and also to any crisis. What we are working on is an increasing move towards harnessing the power of electronic health records for these types of public health purposes. And that is a major focus of our National Healthcare Safety Network as part of the broader CDC effort called the Data Modernization Initiative, an effort to bring public health data systems into the modern age to really be able to focus and take advantage of things like electronic case reporting and automated data submission. And as all of you know, this has a dual benefit, right? Not only will automated data reporting expand the data that we can acquire, it expands the universe that we can see, but it also reduces the burden and gets the data into us faster. So it simultaneously gets more information, but it also makes it easier to gather that information and it makes it faster. A big focus of this is on electronic case reporting, and this is a system by which rather than you having to enter in that Arjun Srinivasan tested positive for COVID, when that test happens for any patient, there's automatically a report that is triggered that goes straight to public health. So it comes right out of the electronic health record system so that no one has to do the manual data entry. But for any reportable condition, all of the necessary information comes straight out of the electronic health record and is securely transferred to public health. And this is a major part of the initial efforts at improving our ability to gather information, both during baseline status and during future emergencies. We want this to be part of the new normal. The pandemic has also heightened awareness of the need to monitor the safety of healthcare personnel. You know, we talk a lot about patient safety, but I would argue that embedded in that concept of patient safety is healthcare personnel safety. When you survey providers about the things that they need, what do you need to provide safe care? The first one is, I need a safe environment. I cannot keep other people safe if I am not safe myself, right? It's that classic concept of you have to put your oxygen mask on first before you help those around you. And this is an area that I think we need to do more. We need to do a lot more of. We need to message about this more and talk about the central importance of understanding healthcare personnel safety. During the pandemic, for example, the data about cases among healthcare personnel have been so important in informing our approaches. Do these infection prevention recommendations work? Is this the right type of personal protective equipment that we should be using? We can't lose that focus on healthcare personnel safety monitoring when COVID goes away. And so one of our priorities at CDC is thinking about what does the future of healthcare personnel safety monitoring look like? We also know that simply telling providers, oh, you know, what we need you to do to prevent this infection is complete this checklist and do all of these things every time you put in a line or every time you access a line. Those are important, and we have to get back to those, right? It doesn't, at the end of the day, if we save someone from a COVID infection but lose them to a central line associated bloodstream infection, we haven't done that patient any good. So we have to get those systems back. We have to find a way to get those baseline safety practices back. But we also have to find new ways to improve the system. Simply telling all of you who are so incredibly busy doing a million other things to do even more to prevent these infections, that's not a tenable and sustainable solution, right? We've just seen the downsides, the failures that come with that solution. We need to be thinking about interventions that can improve outcomes, even if no one does anything. These are challenging, right? I wish we had a lot of these and had the magic answers here, but I suspect that many of you have ideas for ways that we can make the default systems the normal and the safer systems. Things like automatic catheter removal protocols. Those have been very successful in some places. Automatic stop orders or de-escalation orders for antibiotics, automatic ventilator weaning. So these are protocols that have been put in place where the default pathway is the desired end state. And a provider, if they don't do anything at all, the normal situation, what happens in the default, leads to the better outcomes. And we need to seek more of these types of interventions and find ways that we can use them and implement them safely. But in the meantime, what we can do is look for the bright spots, if you will, find the places that achieved success. And from our perspective, we're looking for those places that had success in infection prevention and stewardship during COVID and trying to learn from them. And here's just one example. There was a group of hospitals in Michigan that saw that a real rise in antibiotic use during the COVID pandemic. And so what they began doing is implementing some strategies to address that, right? They began sharing information, doing some very focused educational sessions on antibiotic use in patients who were admitted for COVID, sharing risk factors for people who might have bacterial co-infections, but saying, hey, in patients who don't have any of these risk factors, their risk of bacterial infection with COVID is incredibly low. They probably don't need antibiotics. And what they found is that they were able to significantly drop antibiotic use in patients who were not critically ill, who had COVID, by implementing these kind of just-in-time tailored interventions. We need to find more of these, look for the bright spots so that we can understand where people had success and replicate that experience. There are some things that came about during the pandemic that we should think about maintaining in the new normal. And some of these are some policies that have come into place that may have important benefits as we move forward. And again, for any policy change, there are going to be benefits and there are obviously going to be downsides. And so we need to weigh the risks and benefits of all of these. But these are things that have changed during COVID that we really need to think about considering making part of our new normal. For example, during the pandemic, all CMS certified skilled nursing facilities began reporting information into NHSN about COVID. This was incredibly important, right? That COVID information from the nursing homes has been vitally important in understanding what was going on so that we could bring resources and interventions to bear in order to help solve those problems. But it's not just COVID. We know from the limited information we have that nursing homes face challenges with other types of healthcare associated infections. What could we do to bring some of those infections under monitoring so that we can understand not just COVID, but other types of infections in nursing homes, be they diarrheal diseases, other types of respiratory diseases? How can we collect that information? Again, there's burden associated with that. So we have to think carefully about imposing burden and what burden would be justified in order to have data for action that is truly actionable in the long-term care setting. Which infections would be most important? How do we collect that information? But I think those are the questions to ask. I think we need to keep this reporting from the long-term care sector, and we need to figure out how we can do it in a way that's most actionable and least burdensome. And finally, one other one, this is something new CMS did for the first time. They imposed a vaccine mandate for the COVID vaccine for all CMS certified facilities. And this was a measure that they took because they recognized that this was important in protecting the patients who were receiving care in these facilities, also important in protecting the healthcare workforce. And we saw that the experience that states that had mandates did have higher vaccine rates among their staff. But this obviously comes with a considerable controversy, right? There are pros and cons to this type of vaccine mandate. On the upside, it certainly ensures rapid uptake. And we know from the data that we have that vaccine uptake protects both the staff as well as patients in hospitals and residents of long-term care facility. And it also levels the playing field. We heard from a lot of places that, facilities were reluctant to impose vaccine mandates because they were worried, if I have a mandate, but the hospital down the street doesn't have a mandate, I'm going to lose some of my healthcare workforce to that hospital. So they said, we need a mandate. We've got to level the playing field so that one facility doesn't risk losing staff, and a mandate certainly does that. On the counter side, there were very legitimate counter arguments, right? And one of the big ones is this one. Well, if you mandate something, is that going to undermine confidence in the vaccine? The healthcare staff, wouldn't they naturally ask, well, if this is a good vaccine, why do you have to require people to get it, right? Shouldn't you be able just to provide education to inform people? And won't that naturally solve your problem? Maybe it'll make people even more reluctant to get the vaccine if you require it. So again, I think these are the types of discussions we need to have moving forward. We need to think about the things that changed during COVID and have thoughtful discussions about whether or not these are things that need to become part of our new normal and in what way they might. I hope I've convinced you that our focus after the pandemic shouldn't be on getting things back to the way they were. It should be on keeping the best of what we had before and exploring ways that things could have been better so that we have safer, better care moving forward. The goal should be to have the best systems for patient safety that are going to improve outcomes every day, but also withstand the crises that we know lay ahead. We know the pandemic is not going to be the last time that we face these types of challenges in healthcare. I would argue, this is a point that we made in the editorial that Ray just mentioned, none of us can solve this problem alone. There are so many different stakeholders that need to be involved, and no one has all the answers. No one has all the abilities to implement those solutions. But if we have learned anything during COVID, we have learned that when all of the partners in healthcare come together, we can do the impossible, which makes me so optimistic about our chances of providing better, safer care in the days ahead if all of us come together. And with that, I will stop and let's open it up for some questions. And I think Ray and Michelle are going to join me for some discussion.
Yeah, I believe you're muted.
Ray, you're muted. Oh, there you go.
I'm 70 years old. I take one old man fluff a day, so I'll spend it here. So what I wanted to say to was, Arjun, that was spot on. That was just terrific. I mean, it was comprehensive, focused on what we're dealing with on a daily basis inside our facilities. I really appreciate that. And to the group at this time, I'd like to now invite the aforementioned Dr. Michelle Dahl from the VCU Health System to join me in a brief Q&A with Dr. Srinivasan. Dr. Dahl is the Associate Hospital Epidemiologist and an Assistant Professor of Medicine at VCU. She also chairs the Virginia Healthcare Associated Infections Advisory Group that supports Virginia Department of Health, statewide healthcare associated infection monitoring and prevention activities. Michelle?
Thank you so much. And thank you, Dr. Srinivasan, for such a wonderful talk. In listening to your talk, I was wondering, why do you think that some of the healthcare associated infections, specifically surgical site infections and C. difficile, might have actually decreased in their rates through the COVID-19 pandemic?
Yeah, Michelle, that's a great question. And I'm going to provide my answer, but then I'm going to let you tell everybody what the real answer is, because I know you have a lot more direct experience. A couple of factors we think, with the surgical site infections, the volume went way down for those infections. And so it's hard to know. And we suspect that to some extent, that might have been an impact. And it may be that, those are largely elective procedures that we monitor. And it may be that the places where those surgeries continued were the places that were not really impacted by COVID. And so they were places that were able to implement best practices, and hospital volumes might have been lower. So they might have been able to even provide safer care. They maybe had more resources to manage those patients. C. diff, we're not totally sure on that one. The antibiotic use, as you well know, actually went up during parts of the COVID pandemic. So it can't be explained by antibiotic use dropping. But we also know that there was a lot more attention to hand hygiene, contact precautions, and environmental cleaning during the COVID pandemic. So for C. diff, we suspect that might have been a major cause, but I'd be interested in hearing, what did you guys experience at VCU with your surgical site infections in C. diff, and what are your thoughts on what happened there?
Our trends here have mirrored pretty much what you present on that graph. Are the infections we saw increase are the same that's been the experience nationally, and our SSI data and C. diff data looked quite good in 2020. Interestingly, in 2021, our C. diff numbers were closer back to what they were in 2019. And we too are not sure what is going on there. Potentially really, really great environmental cleaning. We certainly worked to optimize that, of course, during COVID-19. Maybe just the decreased volume of patients in general. Maybe, we do know that the more C. diff we look for, the more we find. There's an issue with colonization perhaps, and it may be that some loose stools were further down on the problem list for a lot of patients coming in at that time. They were just very complex and the focus was elsewhere. So we do not have a good sense either of why that occurred.
That's a really good thought, though. I hadn't thought about the testing issue. You're right, that might have just kind of moved down the problem list until it got really, really severe.
One of the interesting things about the COVID-19 pandemic, we saw the CDC come out with specific guidance based on settings. So there was wonderful guidance for, all kinds of different healthcare settings, as well as down to even daycares and some community settings. Do you think moving forward, we might begin to see more of a tailored approach to guidance for general hospital or healthcare associated infection prevention that's based on site specific guidance for nursing homes versus other types of facilities?
I think that would be incredibly helpful. Especially when it comes to nursing homes, one of the longstanding challenges has been, they're so different from hospitals. People live, that's their home. And so things like contact precautions and a lot of the things we do in healthcare that are acceptable when someone's in a hospital and they're only there for a defined stay really are not acceptable when you're talking about doing this for the place where someone lives. And we have historically, I think, lacked a lot of data and information upon which to make kind of differential recommendations for long-term care. And so a lot of what we've done has been kind of an extrapolation of what worked in a hospital, then we extrapolate it to long-term care. A lot of times we extrapolate it to pediatrics as well. That's another area where the recommendations may need to be different. And the answer is yes. What we are seeking to do moving forward is to try and develop infection prevention recommendations that are most effective and most sensitive to the specifics of the different types of healthcare facilities and different types of healthcare settings. That's going to require some work to gather more information and data to better understand what works. But I think that is going to be critical moving forward, because I think people are more likely to implement recommendations when they really believe that those recommendations are relevant to their specific setting.
Thank you so much for your thoughts on that. I am seeing some questions in the chat. I may move to, if you do have questions, if you would put them in the question and answer so I can go through them. But speaking of nursing homes and settings outside of acute care, there's a question from Arlene. Any thoughts on the nursing homes coordinating holds on the positive COVID admissions from acute care hospitals? We are currently holding patients 10 to 14 days for quarantine, resulting in the backup of acute care beds.
Yeah, it's been a huge struggle, and Michelle and Ray, I'm going to ask you guys to comment on this as well, because this has been one of the major logistic challenges from the start of the pandemic. Right, you had hospitals that had tremendous patient volumes. They needed to be able to discharge patients who were medically stable and didn't need an acute care hospital. But you had nursing facilities, some of which were simply not prepared to manage this type of a respiratory virus, right? They didn't have private rooms, they didn't have PPE, their staff weren't prepared. And so transferring the patients to this nursing facility could pose tremendous risks to the rest of that population. And what we fundamentally need is nursing facilities that are better resourced, better equipped, and better prepared to manage a variety of different types of patients who have different infections in a way that can prevent transmission so that they can accept these patients. And I think it is going to require a lot of coordination between hospitals and nursing homes, including, I think we've seen models of this, and this is where I'd love to turn it over to you and Ray. We've seen a lot of successes where hospitals have been working with neighboring nursing homes to help with things like infection control training in order to get that home ready so that when the patient is ready to go medically, they can go over there. So would love to hear, Michelle, from you and Ray. I don't know if either of you had these types of partnerships or established them during COVID.
Yes, but it certainly varies. But I also need to point out this time we're looking for a break at 10:45. That's like in 2 minutes. So we do need to just wrap up a little bit. And again, I really appreciate the talks. If I was going to just ask one question of you, Arjun, just tremendous presentation, a very broad one, given your experience, your background, your academic role, your research role, your time at CDC, and actually laying hands on patients. Appreciate all that professionally. But I'd like to hear from you just from a personal perspective. What have you taken away from this over the last 2 years? And then we'll have to go to break. Maybe too big a question to toss up there right before break. I really like
a great question. Yeah, for me, I think what this is demonstrating, I think it was something that I already knew, but it just to me demonstrates, the pandemic demonstrated the incredible spirit and willingness of healthcare professionals to do whatever needed to be done. And when I say healthcare professionals, using that term really broadly, so it's providers, but also the healthcare professionals who work in public health. People stepped up. They came to work, healthcare providers came to work despite the risks to themselves, the risks to their families. Day after day after day, they showed up. They worked under incredibly difficult circumstances. The same in public health, people working under enormously stressful situations, working incredibly long hours. So what I take from that is this idea that there is literally nothing that the healthcare profession can't do. If we could combat COVID and manage to take care of patients and manage this pandemic, we can solve the problems of patient safety and resilience. We just need the will to do it.
Well, that's great. Well, Arjun, Michelle, thank you both very much. To the participants, we're going to a good 15-minute break now. We'll be back at 11 on schedule. Thanks, everybody. Thanks, Arjun. Thanks, Michelle. That was terrific.
Thank you all.